Station grant for their Conversations on Justice series to create spaces for dialogues about inequities in healthcare. I'm very excited to introduce Dr. Fumiko Chino as our speaker today. Dr. Chino is currently an assistant attending radiation oncologist at Memorial Sloan Kettering Cancer Center, specializing in gynecological and breast cancers. Previously, she has completed her MD in residency at Duke University. Her research is focused on affordability of care, the financial toxicity of cancer treatment, and patient costs. Dr. Chino has garnered many awards and recently won the Excellence in Equity Award from the American Society of Clinical Oncology. Dr. Chino is currently involved with a newly formed initiative called the Affordability Working Group at Memorial Sloan Kettering, which thinks creatively about affordability in cancer care. And as a quick note before we get started, for those online, please feel free to put questions or comments in the chat, which will be monitored by our team. And for those in person, we'll pass around a microphone at the end for questions as well. So thank you, and please welcome Dr. Chino.
Thank you so much. It's exciting to be here from New York City, although it is slightly colder here, but I'm happy to be back in the Midwest. I'm excited to talk to you about financial toxicity. It's a topic I'm very passionate about. I do tend to talk very quickly, so if there's something I skim by and you don't catch it, please feel free to ask me questions, or you can even interrupt me if something does not make sense. I have no relevant financial disclosures for giving this talk. I try to level set when I talk about financial toxicity, just to introduce the topic with this concept that there's actually slightly more people who are worried about the financial burdens of a cancer diagnosis than from dying of cancer. This is leading to some significant sacrifices for both our patients and their family members. So this is something that truly is pervasive, not for every single patient, but for certainly a significant minority of our patients. This is from the ASCO Opinion Survey from 2018. This is the most recent ASCO Opinion Survey where they didn't ask the exact same questions, but you can still get from these numbers that there is certainly a significant number of people who are worried about their finances just causing anxiety, and also worried about treatment affordability, okay? And again, the thing to always highlight with these things is that it is not every single person who is worried about this, but it is a significant minority, and those patients are uniquely vulnerable to financial toxicity. This is percolated all the way up to kind of our banner medical journal, this concept that patient costs can be a side effect just like any other side effect. And yet we are, we would never start someone on a chemotherapy regimen without warning them that they could lose their hair, or on a radiation regimen without warning them that I could be causing diarrhea. And yet we're routinely committing people to sometimes month-long treatment courses without ever warning them that they could actually be really financially harmed by that. This is something that's translated over to the lay media as well, because quite frankly, our patients understand. They get it. They have in their life met someone, either themselves, their family members, their neighbors, their coworkers, someone who's been unable to afford care and has somehow had to compromise their care related to those costs. And this is where I say, well, I do have a disclosure to say, not that I honestly make so much money from financial toxicity research, I have some small grants, but that I've given a lot of money into financial toxicity. And so the path that led me to medical school to do the research that I do in financial toxicity is really a selfish path. Because when my husband was diagnosed with cancer when he was in his 20s, and then died of cancer when he was in his 20s, we were faced with excruciating costs related to his care because he was underinsured. And those cost burdens were carried by me for over a decade. It's really the reason why I do financial toxicity research, and it's the reason why I will fly anywhere in the United States to give a talk about financial toxicity, because I think it's so important that we get the message out that this is a problem. When we think about financial toxicity, what my mentor at Duke, Dr. Yusuf Zafar, said is that's really a new name for a growing problem. We had gotten to the point in the United States where cancer care, and honestly all medical care, was so unaffordable that we really needed a new term to define even what we were talking about. When we talk about financial toxicity, though, the term is often misused. It's meant to say costs of treatment are high, or, insurance payments are insane, or, oh my gosh, like this EOB is bananas. When we're talking about financial toxicity, though, we are specifically saying it's a patient-facing problem, okay? So there are high healthcare costs, but financial toxicity is the problems that a patient has related to their care. The NCI specifically says, you know what, someone with cancer is more likely to have this problem than someone without cancer. And what I say in my own commentary is that even with health insurance, these high costs are leaving some vulnerable American families adrift in debt. That was me. Again, I do selfish research. I'm interested in this because it happened to me and because I'm hoping that we can work together to change the system from within. Again, level setting to think about patient economic burden. Okay, so not healthcare system costs, right? Not this line that goes up forever, but actually what patients are paying for their care. And this is Dr. Yabroff's study from 2 years ago, specifically looking at the patient economic burden from cancer diagnosis and treatment and survivorship. And what she shows, I think quite elegantly, is that even 10 years after a cancer diagnosis, there are still costs. There are both increased out-of-pocket costs and there's also increased time costs, which is you're working less hours, or maybe you had to retire early, or maybe you're in a different capacity because, quite honestly, you can't do the work that you used to do. And so there are additional burdens, even again, many, many years after cancer diagnosis that follow you. Financial toxicity matters to our patients in specific and discrete measurable ways. Measurable is important, right? In medicine, we have to be able to put a figure on it and then say we either did better or worse. We know that financial toxicity decreases your quality of life. We know that ultimately it erodes your satisfaction with the healthcare that you receive. And ultimately, it actually erodes the quality of care. There's a lot of studies correlating to high financial burdens to lower quality of life. These are just 3 of them. I actually really like the diagram on the left because, quite frankly, it's very, very messy, and that's what financial toxicity is. There are many coexisting factors. There's an interrelatedness of things like quality of care, quality of life, financial burdens, and advanced disease. The thing is that when you have a lot of financial burdens, you're just much less likely to rate your quality of life as good. It's likely to increase your symptom burden. It's likely to lower your social functioning. It's also likely to lower your physical functioning. It actually can erode the satisfaction that our patients have with their care. This is actually the first study that I published in financial toxicity at this point 9 years ago. One relevant thing, we're talking about, this is my first study from 9 years ago. This entire topic area really has only existed for about a decade. And so we're talking about a new and emerging field where anyone can be the next thought leader in this space. So if you're a person who wants to do research on financial toxicity, I think there's room. Anywho, as a medical student, I published this paper. It was awesome. Not the findings, but, the fact that I got to publish something. That showed that people who have high financial burden are just much less likely to rate their satisfaction with care as good. And specifically, the things that get eroded, the actual, in this validated measure of satisfaction, things that decrease are the general satisfaction, the satisfaction with the financial aspects of care. Both of those totally make sense. But what I thought was really interesting is that there's actually an erosion in the satisfaction with the technical quality of care. And if you actually look at the questions that they asked as part of this validated screening measure, it's trust questions. It's sometimes my doctor making me wonder if my diagnosis is correct or if they have the ability to treat me. And you can see how if those start getting eroded, then you're going to start compromising the potential quality of care that's delivered. And so medication non-adherence related to cost is one of the biggest burdens that our patients face, and it's often silent to the physician. So our study at Duke found that about a quarter of patients were medically non-adherent to some medication given to them as part of their treatment course for cancer. That includes 1 in 5 who didn't even fill a prescription related to costs. And I think maybe more terrifyingly, 1 in 20, not a huge number, but 1 in 20 is, I see 20 people in clinic every day. So that means one of them isn't taking a medication because they can't afford it. That's kind of, when you put it in the perspective like that, you realize how common this is. But 1 in 20 who skipped, took less of, or didn't fill their prescription related to their actual anti-cancer medication, their chemotherapy pill. We know that if some things are going down, quality of life satisfaction, we know certain things are going up. We know that the family patient burden is going up. We know their risk of bankruptcy is going up, and ultimately their risk of dying actually increases with financial toxicity. This is the slide that I just argued with for the last 15 minutes, but basically it showed that when you survey patients on active cancer treatment, that they're having to make some sacrifices that can affect both them and the family unit. So our research shows that 2/3 of patients were having to make at least one sacrifice. That includes about half who were using their savings and about a quarter who were going into debt, having to borrow money in order to afford their cancer treatment. This burden increases with time. So if you think about someone who's on a long-term treatment, so this survey looked at people with metastatic colorectal cancer, and you survey them every 3 months, it's just going to get worse. Again, that kind of makes sense. It's important to prove it. But by the end of 1 year of active treatment, 3 out of 4 patients had made some sort of major financial burden related to their cancer treatment, and that was associated with lower quality of life. This has real objective financial harms. Even if you make it through your cancer diagnosis and treatment into survivorship, it's not necessarily over yet. I know that we just talked about the Yabroff study. In our study of AYA survival, so those are patients who were diagnosed and treated with cancer before the age of 40, this is 8 years median after their diagnosis. And what we found is that more than a third had been contacted by a debt collector, had to put off a major purchase, had their credit score decrease. And I don't know if you've ever been contacted by a debt collector before. I have. It is really terrifying. And it is that extra layer of stress when you're just trying to either get through cancer diagnosis and treatment, or for me, grieve in peace, or, for an AYA survivor to put their life back together. This has actual measurable objective harms in terms of, we know that people are being sent to collections for their medical debts. We know that they're more likely to have a delinquent mortgage payment, and we know that they're more likely to have a foreclosure for a repossession related to things that they own, like, their car or their house. This study was actually really unique in that it linked a cancer registry with credit data, and really made some important connections about, again, downstream effects of a cancer diagnosis on our patients. We know ultimately there's an increased risk of bankruptcy. So cancer is an independent risk factor for having to declare bankruptcy. So this is the Dr. Ramsey study that kind of set off the whole field about a decade ago, showing that you were more than 2.5 times more likely to have to declare bankruptcy in the context of a cancer diagnosis. So our cancer treatments are so costly for some of our patients that it's actually leading to the very worst financial outcome, something that can really follow you and your family for decades. And that matters, not just because it's a bummer to not get loans, because if you kind of play the record to the end, for those patients who had the worst financial outcome, they can actually have the worst physical outcome, which is death. And so in the follow-up study, what Dr. Ramsey showed is that for those patients who had declared bankruptcy in the context of a cancer diagnosis, they were just more likely to die. When we think about financial toxicity, and when we think about in the context of healthcare disparities research, they're really inextricably linked. So you can't pull out the financial toxicity affordability aspect in healthcare disparities because they're truly interrelated. So one drives disparities, and then disparities drive the toxicity. So it's just two sides of a horrible, horrible coin. We know that there is a cycle of poor health related to structural racism and disinvestment in communities, where we have patients who are not able to afford, the basics of a healthy lifestyle, and not able to afford even from the care cascade from getting to a cancer diagnosis to actually getting into survivorship. There are blocks along the way for some of our patients in more vulnerable communities. This is expensive. This is a slide I actually just added to my slide deck yesterday, because this paper actually just came out 2 days ago in JAMA. But what this team did was actually just put a dollar price on structural racism. And it calculated out to about $1 billion. And this is something that's borne by our patients in terms of decreased access to care. But even again, those upstream things, the education, the community investment, this is something that's expensive to our healthcare system. And it's expensive to our patients, not just for their bank accounts, for their generational poverty, but also for their lives. We know that there's worse access to care for certain populations. I worked with this study with a stunning undergraduate who presented in Miami at the breast cancer meeting. It will also be presented in a month at ASCO. But specifically thinking about altered care related to a cancer diagnosis, how it differs by race or ethnicity. And so what we found is that, for example, in this study, Hispanic patients were much more likely to have to choose a doctor based on the network they were in from their health insurance, to miss appointments, to spread out their chemotherapy appointments because they couldn't, afford to be off the work that long. And so these things can really matter in terms of, again, the downstream effects for cancer outcomes as well. We know that there's worse financial impact for our patients. We know that, for example, this study from Dr. Wheeler's group showed that there was any worse financial impact for Black women with breast cancer when compared to white women with breast cancer. They were more likely to lose income. They were more likely to have healthcare-related transportation barriers. And we know that there's more affordability concerns in certain populations. So this is research that is also going to be presented at ASCO that I worked with Dr. Stantos at MSK, specifically looking at immigrant populations. And we broke it out into people who were born in the United States, people who immigrated to the United States but were citizens, and then non-citizen immigrants. And what we found is that there were again, this is not rocket science. There were differences in access and affordability. Non-citizen immigrants were much more likely to be uninsured, and they were much more likely to have, immigrants were more likely to have financial hardship. They were more likely to need housing assistance. Some pretty nuts and bolts things that honestly are still upstream of even of a cancer diagnosis, because you have a cancer diagnosis, but you actually are homeless. Which one is more important? I think that we've all in our clinics found someone who, we're struggling with how to prioritize these things. We know that overall there's just worse financial toxicity in certain groups. So this study was a national study of about 10,000 patients, finding that Black patients were 5 times more likely to be denied health insurance after a cancer diagnosis, and more than twice as likely to say that they were harmed financially from that diagnosis. Playing it to the end, of course, Dr. Jiangxi actually did this really beautiful study that was published in Cancer a couple years ago. This is just one of the findings that I found so striking that I have to make its own slide, which is that 1 in 20 Black or Latinx women with early stage breast cancer became housing unstable related to the costs of their medical treatment. And again, 1 in 20 is not that's not that infrequent. Again, I see 20 people a day. One of them I'm going to be making homeless. When we think about early stage breast cancer, our modern cancer treatments make it incredibly treatable, incredibly curable. Our long-term survival is in the high 90s. And yet our treatments can cause so much financial damage that catastrophic insult to their lives could, again, cause generational poverty in them and their families. We know that there's unequal access to clinical trials related to affordability. So there are all of these known costs related to clinical trials, but there's also these hidden costs like childcare and transportation, some things that we don't necessarily know, really, that we're not able to truly warn people about this, but are the real actual barriers why some of our patients consistently don't get offered a clinical trial or do not accept clinical trials. And that there are certain patients that are, again, this is the main concern and it's the main barrier to enrolling. And it matters because our own research shows that actually, for example, in phase 1 clinical trials for Black patients, their enrollment as a proportion of the prevalence of cancer in the community is actually going down. So it's not just that we're not making strides, it's actually that it's getting worse over time, this inequity. We know that there are increased burdens due to COVID-19. So if there's anything that exposed all of the cracks in the sidewalk, it's certainly the pandemic in terms of access to care. So in our study, looking at AYA population, again, a vulnerable population, the younger patients, the older patients, it's not just Black, white, Hispanic, non-Hispanic. It's rural, it's urban, it's young, it's old. There are many ways to look at healthcare disparities in the United States. But when we looked at the effect of the COVID-19 pandemic in this vulnerable population, we found that there were discrete effects. We found that 2/3 had some negative financial impact related to the pandemic, and that this then led to increased compromising of care, things like skipping appointments, things like having a problem and not seeing a provider. These are things that can pay out in terms of cancer reoccurrences even a year, 2 years, 3 years from now. So that was a whirlwind through what I would consider to be the most depressing information about financial toxicity. And we can't leave it there because I have so much air in my lungs and I have a lot more to tell you. But I always try to say, this is what we're up against, but this is how we can potentially help. So we can move forward in many different ways. I do think about, how we get to the point of financial toxicity for our patients, what multifactorial issues that led to it. We know that there's the need for treatment or surveillance. We know that there's a problem with how health insurance is designed. We know that the treatment itself disrupts work for our patients or for their caregivers. We know that we're causing some side effects that may compromise their long-term capacity for being financially stable. And then again, we know that certain populations are just less likely to have savings in the first place. I know that my first study in financial toxicity, I said, one of the questions, did you have to use your savings in order to afford your care? And I had about 1/3 of patients who said, oh, baby, I don't have any savings. I didn't have any savings before cancer. And I had to say, no, did not use their savings, which makes it sound like, oh, they're doing great. They didn't have to use their savings. But there was no other option for me to capture that information. So as you do this research, you realize sometimes even we're not asking the right questions, right? Every subsequent survey I've done after that always has a thing, I don't have any savings to begin with. I left out the baby, but we know that all of these things contribute to ongoing financial toxicity for our patients and for patients in survival. The thing about any multifactorial problem, any multi-level problem, is that there's really many ways you could potentially intervene, all the way from kind of policy to provider, healthcare system level, all the way to the bedside, right? So it's sort of overwhelming, right? Oh my God, how do we fix this problem? It's too big. But if you break it into small pieces, I do really think that there's meaningful steps you can take each way. This problem didn't create overnight. It's not going to go away overnight. But I do think we can make meaningful changes to help individuals, but also to help society and also to help right some inequities that affordability kind of brings to the forefront. Starting from the top, policy. Policy is like the big black box in medical school. No one teaches you about this stuff. But there are some policy changes that could help improve affordability. One of them is price transparency. This concept that price transparency could help is that, maybe if patients realize that there was a stunning variability in pricing between X hospital and Y hospital, they could make maybe better, more informed decisions for themselves about their health care. So there's been a number of CMS rules to mandate price transparency in hospitals. First was the charge master rule, which is kind of a fake rule where you lift these imaginary prices that no one ever used, and then you're like, yay. Less helpful, I'll be honest. The second rule, which started in 2021, was actually negotiated rate, which is more usable, which is essentially like, if I go to this hospital, this is what your health insurance negotiated the rate to be, as opposed to $1 million fake money to like $100,000, which is actually what your health insurance pays. It's a little bit more meaningful. It is not your out-of-pocket expense that was necessarily mandated to be price transparent, but we're moving in the right direction. The reason why price transparency can help is that when care is unexpectedly costly, patients are less willing to pay. My own research will show this, which is essentially if people are surprised by how expensive things are, if they were unprepared, they have a decreased willingness to pay, in addition to obviously having more, they're more likely to have financial distress. What we found from price transparency tools and spending is that they're not necessarily helpful. Very few people actually use them, which is a bummer. And in fact, this study that came out before the CMS rules showed that actually less than 10% of basic employees on this used this tool. And for the people who used it, they actually paid slightly more for their health care, which I thought was really interesting. Regardless, it was not a super functional tool for these people. And again, maybe the bias is that these are healthy employees that were just kind of shopping around. It kind of doesn't matter anyway, I'll be honest, because so many centers are not actually compliant with the price transparency rules. Our own research shows that about a quarter, less than a quarter of NCI cancer centers are actually adherent to the rules of price transparency, which is, again, they're just breaking the law. They're more likely to just take the penalty because it's beneficial to them to remain opaque. And when we did a follow-up study after the penalty actually increased to $1 million per healthcare system, that we found that actually some centers who were previously transparent actually had taken their price tools down in the interim, which kind of makes sense, which is $1 million compared to price transparency. You know, you do the math. I'm sure the business people did, and they're like, we'll pay the $1 million. What was really interesting in our price transparency work is that not so much like the fact that people weren't compliant, because we kind of expected that, but for the centers that were actually transparent, the huge variability in pricing. So we spec'd out of the 13 centers that had actual pricing online. There, for a single fraction of radiation, 4-field box of the pelvis, there was one center charging $300, and there was a different center charging $33,000. Which is a big difference. And I can tell you for 4-field box, there is really no difference. You can get that at Joe's Crab Shack. There's not a 1,000-fold difference in the quality of that radiation, I suspect. So maybe we don't need price transparency. We need something more like price stability. Moving on in terms of National Healthcare Initiative's policy changes, the Affordable Care Act did make a meaningful difference in terms of improving how cancer patients are able to afford their care. One of them is by removing this idea of a lifetime cap, which is what my husband came up against. He had $500,000 that his health insurance said, I have reserved for your cancer diagnosis. Once you spend that $500,000, which, as you can imagine, for a cancer diagnosis is kind of a drop in the bucket, but he was basically cut off. Interestingly enough, he had had another diagnosis. If he had gotten into a car accident, if he had broken his leg falling down the stairs, his health insurance would have paid for those things. But it did not have any more money for his cancer diagnosis. This idea of a lifetime cap was allowed before the Affordable Care Act. It is not allowed now. Things like exclusions for cancer treatments are also not allowed under the Affordable Care Act. So there are some protections for people with cancer. And what you can see from the major initiative from the Affordable Care Act, at least from these graphs, which was Medicaid expansion, there was some benefit for patients who were newly diagnosed with cancer, whether or not they actually had health insurance essentially walking in the door. And regardless of what you think about Medicaid, whether it's good insurance, it's bad insurance, it's generally better than no insurance, with some caveats. I'm not a shill for the Affordable Care Act. Ironically, not ironically, the Affordable Care Act is often actually not affordable. And one example of that is if you have a cancer diagnosis and you have newly acquired health insurance through the exchange, you may not actually be able to get the specialty care that would probably be best for your cancer diagnosis. And so this study showed that less than half of ACA exchange plans actually had in-network access to an NCI-designated cancer center. So again, if you need a higher level of care, you may not be able to afford it anyway. And we know, of course, that healthcare policy and politics are, again, inextricably linked. And as with progression erosions of the ACA policies, we saw discreetly and measurably that people were losing their health insurance. So from the nadir, after all of the provisions were enacted, to the rising after the 2016 elections, we saw more and more people, cancer patients and survivors, actually lose their health insurance and become uninsured. And we measured this at about 200,000 in the US. Big policy changes, the Inflation Reduction Act, it does have some promise to improve affordability for our patients, at least for the patients on Medicare. Part of these provisions are to do things like cap out-of-pocket expenses and to specifically allow negotiated drug prices for some of the most expensive agents that Medicare is paying for. I put in red the most expensive cancer agents that Medicare has payments for. So I would expect some of them would be actually starting to be on this list of negotiated rates. This concept of negotiated rates has been previously barred for decades. And, you know, Medicare is a big buyer of pharmaceutical drugs. It does seem like this could be a way of making those drugs more affordable for the millions of people on Medicare. There's Medicaid reform. So I specifically want to call out again, some of my work is specifically within immigrants. And there's a real gap in care for undocumented immigrants in the United States. So we put out just a perspectives piece in the New England Journal of Medicine earlier this year, which I was honored to mentor Dr. Santos on that. And specifically looking at the differences state by state for how an undocumented immigrant with cancer may receive care. And the answer is varies widely based on where you live. And we know based on research done from undocumented immigrants who are receiving dialysis that there are huge cost savings related to just getting them some quality healthcare, even just the bare minimum. Just things like scheduled dialysis. You can make a huge difference in terms of reducing the chance that they're going to show up in an urgent care, reducing the chance they're going to be in your emergency room, reducing the chance they're going to be hospitalized. And again, you can save money by just meeting that need in a population that needs it. There is a role for national advocacy. So again, everyone here can advocate to their legislative body, either at a local level, at a state level, or a national level. I put this slide in here because I was just at ASCO Advocacy Day 2 weekends ago. And next weekend, I will be in DC again for Astro Advocacy Day. But this is an opportunity to actually lobby your congressional representatives to help your patients. You have a lot of power being in healthcare, being a trainee, being a physician, being able to tell people what's happening in their district is huge. And so this is a narrative about 2 bills that I asked my congressperson, Representative Nadler, to sign on for. And then the 2 responses that I got, which is I met with the representative on May the 2nd. On May the 2nd, Representative Nadler signed on to the Help Copays Act, which is amazing. And then I asked them to support a letter that was specifically about the role of prior authorization. And then a week later, I got an email that said that he had signed on for that. I am not trying to make an outsized argument about my power, but I do think these advocacy campaigns work. And it's so silly to be like, oh, how does my voice matter? I think it matters. I think if you get in front of someone and you make a compelling argument, you can change hearts and minds. There are other national healthcare initiatives that can improve affordability. One of them is just decreasing waste in healthcare. So if we're doing things that don't have a lot of value for our patients, maybe we should stop doing them. The Choosing Wisely campaign was rooted in that idea that maybe we can get rid of the low-hanging fruit. And the Choosing Wisely guidelines are really helpful for me because when I have someone with DCIS in my clinic, that's a pre-invasive breast cancer that has literally, by definition, no chance of spreading in their body, who's telling me, demanding why I'm not getting a PET scan for them. I can explain it with evidence, but I can also say, hey, there are national guidelines that say I should not get a PET scan for you because it is not indicated, it is not going to help you, and it will only cost you money. And so Choosing Wisely actually really helps facilitate some of those conversations. And by having guidelines, it can help guide care to be more value-based for our patients. We can do research that actually highlights medication waste. So I point to this, which was on the plenary stage of SGO, which is the Society for Gynecological Oncology, last year, that highlighted the idea that this specific medication called lenvatinib was in these blister packs. So they had this unique packaging. You can see this sometimes in the DOACs, the blood thinner medications. But it was like a dose pack. And because the clinical trial published in the New England Journal of Medicine, the best of the best patients on that clinical trial, 70% of them needed a dose reduction. So in your clinic, 100% of your patients are going to need a dose reduction of this expensive medication. And the fact that you had to get a new blister pack meant that you had to pay another $23,000 because that's how much that medication cost. And that led to a waste of millions of dollars. By her going on stage and, let's be honest, publicly shaming this pharmaceutical company, they actually came up to her and said, hey, we promise to have an unrestricted pill exchange program. Thank you for pointing out the problem. We're going to fix it. And that's the fastest translation of research to patient benefit I have ever seen. That is actually what I dream of when I think about the research that I do that can help patients. And so our research can make a difference, is what I'm trying to say. This is a complicated way of saying it, but our research can make a difference. We can think about early integration of palliative care because I think there is a lot of value in palliative care in terms of reducing symptom burdens, improving quality of life, and sometimes actually improving quantity of life, but also in reducing costs. And I think there's a potential real role for our palliative care physicians who do more better. They possibly maybe better shared decision-making conversations, goals of care discussions, to be integrated into some of these discussions about what's worth doing for them, not just for symptoms, but also because of costs and how it's going to be reflected on their families. We can think of true healthcare disruption, so taking it out of the box completely, right? When the Walmart $4 list debuted, it changed how primary care physicians prescribed antihypertensive medications because you're saying that someone can just go to Walmart and get this pill for $4 for a month. I don't know why you're on verapamil. I'm getting you right on to metoprolol. Beta blocker it up, okay? That made a huge difference in terms of prescribing patterns, and we've evolved from there all the way up to Mark Cuban's Cost Plus Drugs, which is now offering some limited cancer treatments at a much lower price and without health insurance by essentially streamlining the process, doing a 15% markup only, and shipping directly to the consumer. This can be a huge difference for our patients, and I'm going to tell you right now, and I don't know if it's a shock to you, Mark Cuban is not doing this as a charity. He is a businessman. He's the Shark Tank guy, okay? So truly thinking outside the box as a business person of how do I exploit generics and a gap in the healthcare system, you can generate new ideas that can help that millions of people. Everything above the box is kind of at a level above the bedside, right? So I want to focus the last, let's just say 15 minutes of this talk on the things that we can potentially do at our healthcare center level or at the patient level. I really do think of this as a public framework, health framework, which is like, primary prevention, secondary prevention, tertiary prevention. What's the vaccine to help prevent financial toxicity from forming? What's the rapid test so we can diagnose it early and so, it's less likely to cause harm? Or for someone who actually has it, what's the treatment so that we can cause less chronic effects? What's the Paxlovid in my COVID analogy? So how do we prevent it from forming? I do think that education makes a difference. That includes for both patients and providers. So just sitting here listening to me wave my hands wildly and talk very passionately about this, I think can charge you to think about how you can improve affordability wherever your day leads you. And that's true again for patients too, to realizing that this is a kind of a normal concern. Affordability is a concern. I think we can be doing more to help navigate patients to resources. And then again, being maybe more proactive in our financial assistance versus reactive. So instead of someone getting to the pharmacy and the pharmacist telling them it's going to be $5,000 and then them leaving the medication there, or worse, paying the $5,000 and making other compromises in their lives and then not showing up in your clinic in a month because that was it. They had money for $5,000. They don't have money for anything else now. I think that can make a difference. I think, our work to improve access for our patients, like thinking about how do we arrange clinics to be more friendly for our patients. Telehealth is one of those things that could potentially help. How do we practice value-based care? How do we eliminate low-value care? Again, kind of choosing wisely ideas. How do we streamline our clinics so people aren't waiting around for 4 hours for my 20-minute slot? And how do we advocate on our own cancer center level for practical solutions? I think there's a lot of benefit for education. It does not necessarily lower costs, but I think it helps inform patients better for their costs. And that's not nothing. So just having people meet with a financial counselor can help them prepare better. And I think that can make a meaningful difference. This was actually a randomized control trial for that. There was one trial that did show financial counseling could help actually lower costs, or maybe more specifically, the financial toxicity didn't rise for the people who got it, as opposed to it rose for everyone else. So I guess not rising is still winning. And in this situation, it wasn't even really meeting with a financial counselor. It's just they got a letter in the mail that said, these are your benefits. This is what your expected costs is for you. This is for patients treated with radiation for head and neck cancer. There's our percentage change, but I think we can improve medical education because our survey shows that the vast majority of trainees have met someone who couldn't afford their care, but also feel that their education is pretty marginal or insufficient. And specifically, there was a significant portion who had never had any, not even a lecture, had any education on affordability or costs. And thankfully, we may be making a little bit of changes because more recent graduates were more likely to have had at least a lecture or a slide. But there's, again, big gaps in our education. I think, again, this idea of an affordability curriculum can make a difference. Thinking about how do we teach value? How do we even teach about health insurance? Because I was not, as a medical student, taught anything about what health insurance design was, what it pays for, what it doesn't pay for. I had someone tell me that hospice was free, and I was like, well, not really. Not really. Most of it is just borne on the unpaid labor of your family. Technically, hospice is a benefit, yes. So I think we have a huge gap there. I think there are some simple practical solutions to improve affordability that we can do at our hospital level. So things like, again, minimizing wait time so that people can just go back to work, especially if they're there for, again, a 20-minute follow-up visit. Parking can be a huge expense. Our own study shows that parking rates can be up to $40 a day. Again, I'm in Manhattan, so that was definitely us in Manhattan, the $40 a day parking. But the fact that we're charging patients with cancer to park at the facility where they're getting their cancer treatment is like a big insult anyway. I wanted to highlight this work from Dr. Chen that was published earlier this year in JACR, specifically about work that was actually implemented here about the idea of rideshare, this concept that maybe if we can actually help people get to their radiation appointments, something that's every day, that it actually could, number one, help people get to their appointments. Again, not rocket science, just get them there. They want to come, they just can't make it. But that it could actually essentially make up for itself, because when you don't treat someone, then you've just lost the revenue of treating that person. So it's sort of lose-lose. So just by helping people actually get in the door, you can help support the healthcare system, but also, again, hopefully more importantly, actually get the patient the best care that they can receive. We can help people get to clinical trials. So just an equity intervention that was piloted by Dr. Nip when he was still at Mass Gen showed that if you help offset travel costs for people enrolled in a clinical trial, they're less likely to have travel-related financial burdens. Again, that is a no-brainer. But I think it's helpful to do the studies that show, yes, helping with flights or hotels or food can make a difference. These things that are soft, right? It's not the drug, it's not their health insurance. It's just getting to the things where they have access. Telemedicine can help. Our study showed that 2/3 of patients said that telemedicine was better at treatment-related costs. So that includes time off of work, transit, that sort of thing. Amongst many things, telemedicine can improve. This is one of them. And then we can use technology. So just navigating people to the resources that they actually qualify for and then helping them apply can make a difference. This study found that you could triple the rate of people who both applied for and received financial assistance through an app. You gather everyone together at a healthcare center that is interested and engaged in these issues. You put them all in a room. and make them find solutions. And that's what Levine Cancer Center did. And they published this really nice evaluation of the fact that just gathering executive suite to the social workers, to the providers, to the patient financial services group together once a month to troubleshoot common issues could help thousands of people and also save millions of dollars. How do we reduce the impact by diagnosing financial toxicity early? We can screen. I think yes, no questions totally makes sense. This is the NCCN problem list. If you use it in your clinic, great. I very rarely ever see this if it's ever given to my patient. So who knows what they're checking out on that. The nurse takes it and then it disappears. But we can ask yes, no questions. I think that could be very easy to do. There is a validated screening measure for financial toxicity. It's called the cost score. It takes about 5 minutes for patients to fill out if they're in the waiting room and has both objective and subjective measures of financial distress. I think we cannot miss the fact that we need to potentially be screening for some of the social determinants of health and also sacrifice that our patients are making. So again, some simple questions. Do you have enough money for food, clothing, housing, repairs to your home, transportation? Again, some really straightforward questions. I think the problem and the barrier that a lot of people have about asking these questions is that they don't know if they can afford the extra staff to then help the people whose need is uncovered. And so they'd rather just not ask the question. We know that if you screen people, that providers can respond, or at least that's what our survey would imply, that providers actually do want to know. So the majority of providers felt that they should be aware that they could potentially change the plan for a provider for a patient if they were having problems with their costs, and that they should even consider things like national guidelines to improve affordability. As you know, we're ill-equipped to do so. So very few people get training on this. So not just a lecture or a slide or a class, but like anything at all about a cost conversation, and about, when we think about our role in, for example, prescribing expensive medications when there might be something cheaper available. I think, many people would say, yeah, we have a role in that. We can potentially modify the plan, even if it's Zofran versus Compazine. I give out Zofran like Tic Tacs. If it's not covered, illness or injury in my last 13 minutes. Cost conversations are the easiest thing, I think. I'll be honest. We know that patients care about their costs. The majority of them actually want to have a conversation. The minority of them do, which I think is sad. And not with their healthcare provider, but not with anyone in the healthcare system. And we know that it matters because they can help. It doesn't help lower costs to zero for every single person. Nothing will do that. But it can help in meaningful ways. And the way it helps is actually, honestly, it's like a misconnection. It's like just getting people the help that they actually already qualify for. So referring to the appropriate financial assistance. There does need to be a financial assistance person. And that's one of the things in like MSK when we were boning up our program is that we actually needed to hire more financial assistance people. There was an investment at the institution level to make sure that we had someone there to catch the football. Sometimes, appealing to insurance can make a difference, switching to less expensive medication. Most of these don't actually have anything to do with compromising their actual care, not changing the plan, really. And when we think about kind of these initiatives at the bedside, we think about education, we think about trying to eliminate low-value care, we think about screening, asking these questions, and then normalizing cost conversations, making sure that we're using every avenue to help our patients. That's, I think, how we can make a difference for, I'm going to see 8 people in clinic tomorrow. That's how I can make a difference for those 8 individuals. I will end it here because I'm officially out of breath. Mitigating financial toxicity is possible in the United States. So we can't, I really truly believe, I don't know if we can eliminate it, but I think we can mitigate it. And it's a real problem because it's growing. And ultimately it matters because cancer outcomes are at risk. We spend a lot of time at the bottom of the pyramid, putting a Band-Aid on an arterial wound. In our clinics, trying to help people with the parking voucher when really they have a $100,000 medical bill. It doesn't mean that we shouldn't give them the parking voucher. We also should be trying to flip the pyramid. We should be spending a lot more time and efforts in things that can help prevent the problem from forming in the first place. So again, I don't think we can feel helpless with our Band-Aids and all of this blood. I think we should put the Band-Aid on, and we should also advocate for real sustainable solutions. This is a comic I wrote for the LA Times with my colleague, Dr. Gray, specifically about how we have this false dichotomy in the United States, this concept that it's your money or your life, and especially with any kind of critical illness, you have to choose between bankruptcy and death. What I know from my own personal experience is that you can lose both, and our patients are routinely, not every single person, but you can die from cancer and still leave your family financially bankrupt. And when my husband died, that debt and that weight left me emotionally devastated and financially devastated. So this is what we're working to improve in the United States, in America. I think we can make small improvements. And that's what I'm asking everyone here to try to do tomorrow and the next day and the next day. Thanks for your time. I'm happy to take any questions.
That was an excellent talk.
Thank you.
Very inspirational and very helpful taking care of our cancer patients. I've noticed, I've been in practice about 5.5 years, that there are more and more savvy patients and families that when I see a patient with stage 4 cancer, they are like, look, I don't even want any of this stuff because I know how much this is going to cost, and I just want to go home. And we're seeing more and more of that, particularly with the economic and political climate that's been happening. Have there been any studies looking at that, the number of patients who are just refusing care altogether, knowing this financial toxicity burden that's happening? And, as a physician or a caretaker, how do you have those conversations?
No, I think it's a really good question because certainly you want people to get the best care for them, including if it's no care, right? And that's part of this whole model of shared decision making, which when I talk to trainees about this, I'm like, hey, there's this idea that we should talk to patients about what we should do and that they should be an active participant. It's new. We didn't used to do this. We should just tell people this is what you're getting. I do think that it's important for shared decision making to talk about, again, the true side effects of our treatments, the best case scenario, the worst case scenario. I don't know of any studies specifically about the people who decided against care because of cost. We have some survey data specifically for people who had end of life, and then actually, interestingly enough, some survey data of caregivers after the patient died to assess kind of their ongoing financial burdens. But I don't know of any research specifically for that question. But I think it's an opportunity to kind of think about how do we make sure we're improving communication, because we know that for certain patients, they are often misunderstanding our prognosis for them, either sometimes too little time or sometimes too much time. And the most famous is the Week study that showed that there was a portion of people with metastatic cancer who felt that a strong proportion that felt they could be cured from their chemotherapy, which does happen occasionally, but it is not something, it is truly the miracle. So I think that we could be improving communication about all aspects of this. And I think as physicians, we also kind of have to work against our own nature, which is to say, no, you should get care. It can make a difference for you. I have a study. I remember as a medical student at the VA, I had a patient who just wanted to go to the Grand Canyon, and he had metastatic colorectal cancer, and the fellow was like, it was medical student versus fellow, which is never a good dynamic. The fellow was like, no, there's a study. It's great. It shows that they can get this many more months. I was like, he just wants to go to the Grand Canyon. Why don't we just let him go to the Grand Canyon? And then if he makes it back, yeah, give him the chemotherapy then. I mean, that's a goals of care discussion. His goals of care was to go to the Grand Canyon. I have this all the time with people who are swallow hazards, but they want to eat. I'm just like, just let them eat, yeah, they're going to aspirate. My father-in-law aspirates all the time. He's got a peg tube, but he just really likes drinking milk. and it's worth it for him. So again, that I love the question though, because I think we could be doing better, not just about having cost conversations, but trying to figure out what really matters to our patients. What are the meaningful endpoints for them? And it is not often, it's not even months or days or years. A lot of it's birthdays or graduations, or I want to make it until my grandbaby, gets married, like these kind of more intangible things. I'm not sure if that answered your question, but I'm going to take that as a win.
We'll take one question from the chat and then we'll come over. Is that okay? Thank you. So this is from online. This is from Dan Spratt. There's a long sort of build up to this, but I'll go ahead and read it because I think it's important. So he said, inspirational and eye-opening talk. One major obstacle to making progress is that pharma is trying to give as much dose for as long duration as possible and push for approval of therapies with minimal clinical benefit. Even when dose-reduced forms or shorter durations are equally effective, but they're unwilling to be rigorously studied. Yet physicians end up pushing drugs with massive costs, large degree of toxicity, with most patients failing to derive meaningful benefit. So as a radiation oncologist, one of the most cost-effective forms of cancer therapy, how do we shift the culture to promote cost-effective therapies for physicians and patients? It feels like we are trying to push drug over procedures like surgery or radiotherapy because pharma lobbyists, and then there are $2 signs, which I assume means money, money.
That is such a good question. And I do think this is a relevant, again, this is a higher level. This is the top of the pyramid, not the bottom of the pyramid. And so that's why, when you think about how we design clinical trials, how drugs get approved, and then ultimately who's lobbying who and with what money, that's so important. And I always say as a radiation oncologist, it's hilarious how often we're trying to omit our treatments in lieu of an expensive immunotherapy. Pembrolizumab actually billed more last year than all of radiation oncology services by CMS in the entire United States for a single drug. So the value of something like radiation is actually immense, and we're honestly not doing a good job at showing that. So our own onus is to prove that our treatments have value and to make sure that our voices are being heard at things like national societies, like larger societies. As a radiation oncologist, we're so narrow in our own group. We're thinking ASTRO is the pinnacle of everything. There's larger groups like, for example, ASCO. Being a member and being active and engaged can make a difference. But absolutely, it is not minimum tolerated dose that we're finding on these trials. It's maximum tolerated dose. And a lot of the trials are designed specifically to see, what's the benefit of X, but also a year of ongoing therapy. And so the trial I'll point out to is actually the DEBRA trial, trial that was just launched by the NRG, which is specifically emitting radiation for HER2 positive breast cancers. And they're still going to get HER2 therapies, which is very funny because we know radiation has benefit, and we know that there's already trials that showed that 6 months of HER2-based therapies was not inferior to 12 months of HER2-based therapies. And so instead of going back and trying to answer that question a little bit more elegantly, we're going to try to emit radiation. And I know there are many backdoor conversations about all of these, but just making sure we're having the best people in the room when we're making these decisions about trials can make a huge difference. So it includes patient advocates, but also includes everyone in that specialty. I realize I'm taking the mic and just going to a slightly different thing, but even when we think about NCCN guidelines, when you think about true representative of who's in the room even making these guidelines, it is mostly medical oncologists. I know this because I have the receipts. So if you think about, again, who's in the room making guidelines, that makes a difference. It's Hamilton, who's in the room when it's happening, it matters. So if you're involved in clinical trial design, if you're advocating in the society level, if you're advocating on the guidelines level, it makes a difference.
I have a question about Oh, thank you. I did a year back in New York City, but in Brooklyn with my internal medicine training, and we saw a lot of patients, undocumented, uninsured, coming from the Caribbean that needed a lot of advanced level care, but many of them only got palliative based treatment. And when you think about MSK, think about even here at Case Western, Case Comprehensive Cancer Center, like, we are a NCI designated center, but we only ask for patients that have insurance, or that's a significant barrier, you know. So can you comment a little bit about what we can do as residents, as, you know, physicians, to advocate for those and try and capture those patients earlier? Because screening, you know, getting all that stuff, is you need access to care. And a lot of these are minorities, you know, patients, people of color, and I feel like I'm not doing enough justice being here, only because I'm not capturing the right patients or the ones that I want to try and impact.
Yeah, no, I think you highlight some of my own deficits, is that I'm telling you about all this affordability stuff, and I'm coming to you from Memorial Sloan Kettering, which is one of the, you know, ivory tower cancer centers that only, I always say we shut the door in more people's faces than we open it to. We have a to be desired payer mix. We treat very little Medicaid. We treat essentially no one uninsured. As a, you know, quaternary cancer referral center, we're kind of getting the best of the best. So how do we treat the people who are not getting in our doors, right? So how do we try to open the doors up wider? Some of them are community initiatives. So for example, at MSK, we have these cervical cancer screening initiatives, which is essentially like, if you're able to, you know, go to these buses and do your own pap smear, which is like this, you know, self-administered pap smear, like, and we diagnose you, we're able to get you facilitated access to the center without health insurance, or, I mean, we get it along the way. But, you know, I think there are these programs, and I think fostering the growth of those programs can be really huge and beneficial for certain communities. It depends on community investment. You can't just like fly in with a bus and say, you know, swab yourself. You know, you have to make investments in those communities. But I think it can pay out. And the example I'll give is that, you know, MSK was one of the COVID vaccination centers in New York. And we, you know, honestly, we're not getting a lot of people walking in the door, I'm here for my COVID vaccine. So, but when we partnered with the Abyssinian Church in Harlem, we were able to establish a clinic in their basement and in the community, in a established, trusted purveyor of trusted information. It's a church, but they provide a lot of information for their I was going to say encatchment. I don't know what it is for a church, but their, you know, their congregation. Thank you. And that was a way of actually getting the help to the people who need it, right? So I think those community partnerships can be very, very powerful. I think expanding how we consider health insurance and who is able to get it can make a huge difference too. So even making an argument to just hire more social workers, I think, is an investment in the community, because they're the ones doing the hard work. My partner is a social worker, and that's, you know, half of what he does is just getting people into the right programs that they qualify for.
Online and here, we will be providing a whole copy of the talk today. So thank you, Dr. Chino.